I can do nothing but let you down after an introduction like that. So thank you, Greg. My job is to talk to you about monitoring disease, and feel free to ask questions, and I'll try and explain as we go. Both NUPA and FAITH have introduced monitoring up to now, but I wanted to try and take you through the whole process so you understand where we're going. And to do that, I need to just reiterate some of the things that they've said. So I like to build models and make things very simple. The more simple you make things, the more you can understand it, and the more you can make predictions. So this is a very simple model of myeloma where the disease actually starts in your lymph glands, where something goes wrong. The cells move to the bone marrow, where they grow, they change their microenvironment and kind of stimulate new vein formation. And then they can grow into lumps of disease, and then they can grow outside of the bone marrow. So that's a very simple way of considering the whole process. And Faith, bless her heart, stole my slide and turned a marble analogy into a sweet analogy. But what's important about it is that she made the point that cancer cells are not like this, where they're all the same. They're like this, where they're all the same color, all related, but you can see they're different sizes and different shapes and have different behavior patterns. And so you come to Darwin and the Galapagos Islands and these finches. And so the basic premise is the finches' beaks change because they live on different seeds. And so one finch has one type of beak, the other finch has the other. So this is like a cancer cell living in your bone marrow, where one cell gets used to living at this site in your bone marrow and develops one set of characteristics. And another cell lives at this part of your bone marrow and gets characteristics which allow it to live there. And the basic premise is that these different cells compete for dominance, and the one that's worse comes to dominate the whole bone marrow. And so you have these branching pathways, and you move from muggus to smoldering to myeloma to plasma cell leukemia. So these have important features, and so you have this cell that goes wrong, and it seeds the bone marrow all over, and then one starts to grow better, and that yellow cell pushes all of the other cells out in a sort of clonal sweep, and the disease becomes worse. So that's the natural progression of myeloma if you do nothing, is it gets more and more diverse, grows worse and worse and worse, and the question is, how do you stop that happening, and what does that mean when you choose treatments? The other thing that is relevant here is this. So it's not just the cancer cells you need to consider, it's the bone marrow microenvironment and the immune cells. And so we now know that if you kind of let the disease come to dominate, it changes the microenvironment, impairs your immune system, and changes the soil, as it were, so that the weeds grow better. And so there are three very important components. So it comes to this idea about what do you do with treatment, and so what is treatment all about? And so you've seen the iceberg, and we'll come back to icebergs in a minute. Can you see this? Yeah. So we can only see, when we look down the microscope, the very tip of the iceberg. So when the doctors are talking about your disease responding, and they say it's gone from 50% to 10%, although that's a great response, you've still got in this context, almost a kilo of tumour cells left in your body. And so what we're aiming for these days is to get to no disease at all. But how do you tell there's no disease at all? Because you can't look below 1%. And that's where these new technologies come in, called flow cytometry and PCR and NGS. And those cells can look at these states down here, which are considered minimal residual disease states. So you hear doctors twittering as they do without any thought for the patient about, you're MRD negative. And you go, well, thank you, doc, I'm MRD negative. What the hell does that mean? And it's very important that you understand that those are the lowest disease points that you can get to. And if you have a test that will find one tumor cell in 1 million normal cells and you can't find anything, that's a really good prognostic feature. So if you get to that point, your outlook is really good. And so what's changed is that people are aiming for MRD negativity now, aiming to get no detectable tumors so that we can improve people who are alive at 10 and 15 years after they've been diagnosed. So in here, this is what I'm trying to show here, in that you get to these levels where you can't see those cells, and what you're hoping is that you can control the disease long term, and that's where the maintenance comes in, which either gets rid of the cells totally or gets them to such a low level they don't have any friends helping them to grow, and then arguably they may never come back in your lifespan. And so it's a good strategy, and I think it's playing out in a number of trials. The maintenance works. People who are MRD negative have the best survivorships. So this is a complex picture which aims to show what your myeloma is. It's not a single thing. It's got these different ecosystems. So like, I don't know, like different, like a pond here with one set of things growing in it, a pond there, different ecosystem with different animals in it. And the tumors like that. So it's not one thing. So what do you do? So I live in Arkansas now. There's a lot of hurricanes. And so it's like a hurricane ripping through a forest that wipes out lots of things. But what does it wipe out? What is left? How is it doing that? And what's the best way to control that hurricane? So you need some special ninja rules for using chemotherapy. And doctors stick to these rules because they've been worked out over years. You don't use one chemo agent, because if you put one chemo agent on a pool of cells with different sensitivities, you select for the cell that's not sensitive and grows out. Similarly, if you use one set of mechanisms to start with, it will kill all of the sensitive cells. If you come along then with a mechanism that's different, you'll likely kill the cells that are left. So it's like treating chest infections with antibiotics. You hear about resistance to antibiotics. We have cancer cells that are resistant to chemotherapy. You should use the cells or the chemos in the correct order. So we have induction, transplant, post-transplant consolidation, maintenance. So you have 4 settings there where you can use different mechanisms and different combinations. And that's one way you can overcome the resistance or small resistance subclones. If you give a high dose, you kill more. And so with melphalan, that's why 200 milligrams per meter squared is the optimum dose. And if you reduce the dose, you don't get such a good effect. And so back to the iceberg. So we need to just recapitulate this monitoring thing. So you have the iceberg. We're only looking at the top of it. and you can measure the height of the iceberg in polar bears. So at the beginning of treatment, you've got 5 polar bears worth of disease. Where you want to get to eventually is no polar bears at all. And you can see what happens during your treatment. And the people in here that have gone through treatment will know that they have induction. The doctors get all excited because you've gone down to 2 polar bears worth. You then have the transplant. 3 months after the transplant, you might have 1 polar bear's worth of disease. And then ideally you go on to maintenance, continue that, and then the polar bears are no longer detectable. Everybody's happy because you're talking about long-term outcomes, 10-year survivorship and beyond. So it's good. So how do we work out what's going on in between? So now it gets complicated. There's this Clonal approach, which adaptive cell, and so they're a company in Seattle that have just taken this over. They've reformatted the test. It's not been good up to now, but now they have good quality control. It's effective, and this will detect 1 tumor cell in 1 million normal cells. So if you're negative by that test, it's really good. And for completeness, it's measuring markers that are present on all of the tumor cells, and so doesn't go negative and is pretty effective, actually. The other approach of this kind of laser flow cytometry approach is where you stain the cells with different colors, then you use those colors to identify the tumor cells, and they're perhaps a little less sensitive, but if you go to the clinic, you'll get this result when you're being seen. If you want the adaptive test, it goes to Seattle and comes back a month later. So it swings and roundabouts. One's a bit more sensitive, one's a bit quicker. So what else would you monitor? So the people from Arkansas or from Mississippi that come to Arkansas are used to having bone marrows, and I think it does give useful information. Doing it annually is good. More frequently can be a little of an imposition. And so why don't we go for blood tests? Well, it's because they're not so sensitive, and theoretically they can never be as sensitive as doing the bone marrow test using that adaptive technology. It's always going to be 3 logs less sensitive. So at one level, you're better off having the bone marrow done, because it's, you know, even if the technology gets better, it's never going to get to the sensitivity. So to look at really low levels of disease. So liquid biopsies do have a benefit. So I'm not saying don't do them. I'm saying that the difference about a liquid biopsy than a bone marrow biopsy is you might have it done every month, say. Not that I'd be encouraging you to have it, but you could. It wouldn't bother you. You send it off, you get the data. So you have information over time. Because if you're just sort of having the test done once a year, maybe you could relapse at 6 months and you wouldn't know because you haven't done the bone marrow biopsy. So it does give you more flexibility with your testing strategy. The other thing is that I think therapies are changing, and we'll come to that this afternoon. And in terms of, I've told you about very sensitive tests that just say yes or no, your tumour's there, your tumour's not there. This test aims to show that you can characterize the tumour, you can tell what the clone is there and what its mutational state is, and you can see that there are different levels of sensitivity. Down here you have the flow and NGS. Up here you have the circulating DNA, where you might find mutations, and you might be able to start treatment just based on a blood test that stops that clone coming back and puts you back into a remission. So I think the future's going to change. It's not going to be about induce a remission, you stay in that forever and you're cured. It's going to be about monitoring, understanding what's happening at low levels of disease and controlling the disease at very low levels. But you also need to think, so I talked about resistance, pools of cells, and you put a selective pressure on them, and so what's left after you've in a remission? Well, almost by definition, they have to be the most resistant cells, or they're mutated, or they're protected in the environment because they've gone to sleep and aren't accessible. So maybe that's how the maintenance treatment works. It gets cells when they start to wake up. And so this is a tree starting to grow after the hurricane's swept tornado. The tornado has swept through Arkansas. And so this is analogous to the relapse. And so if you study cells at relapse, you can infer what the cells were like when you were in a remission. And this is some information about what happens at relapse. And this is the treatment. And so if you've got a good response and achieved a CR, it's almost always this branching evolutionary processes, consistent with you having eradicated all of the cancer cells and some resistant low-level disease growing back. In contrast, if you don't achieve a complete response, mostly the patterns are exactly the same and unchanged since the disease progressed or presented. And so it's not about mutation, it's about changes in the microenvironment and the disease changing the microenvironment to make it grow more efficiently. And so that's a long-winded way to get to induction treatment. And so the ninja rules apply here, and you can almost see it in this picture, which shows response rates for a variety of drugs. So you almost always get better responses if you have 3 drugs compared to two drugs. Last year saw, 5 clinical trials proving that triplets almost always do better than doublets, and for fit people, triplets and above seem to be better. It's not always the case if you're frail. If you're older, certainly Revlimid and dexamethasone is a good treatment. The debate about transplantation rages on. I don't understand it myself. Our colleagues from the FABA and their French colleagues proved, more or less, last year that if you have a transplant, you survive free of disease for longer than if you just have a chemotherapy combination. And there were 3 other studies that showed that. There were also studies and a line of evidence supporting double versus single transplantation, but that remains, I think, unproven as yet. Consolidation, the French started treatment with consolidation. I think a number of studies have looked. This is an Italian study, showed that VTD after transplant improved outcomes. So I think we're in a position now where consolidation becomes a key area of therapy. And you can take those, the way I said, so you induce, you respond, you don't. You do the transplant, you respond, you don't. You then got consolidation, use a different mechanism, and then use maintenance to control the disease long term. And I think these sort of figures, this is the PFS from the UK study of maintained versus non-maintained patients, where there's a highly significant improvement in disease-free period, and there's a meta-analysis showing that survival is increased. And so how do we go further? And there was the kind of last part of the request was to talk about clinical trials and what should we look for. Well, I think the thing that's really changed are these immune type therapies. The IMiD drugs alter the immune system, enhance it. I think they combine well with these antibodies, and we have daratumumab, which clearly is effective in the clinic, elotuzumab. But these different shaped antibodies, these bispecific that fix the T cells to the tumor cells, seem to me to be something that's really going to change the future and may even be more effective than these CAR T cells because they're an off-the-shelf reagent that does the same thing. Thank you.